Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Okay, let's unpack this. You know that feeling when your morning coffee gives you that focused edge? Or maybe the relief you get from a decongestant that clears your sinuses right up? Those aren't just like minor effects. Those are actually examples of substances interacting with your body in a really powerful way, kind of mimicking your own internal alarm system. We're talking about sympathomimetics. So today we're diving deep into sympathomimetics and amphetamine's toxicology. Our mission really for you is to cut through some of the complexity around these potent compounds. We want you to understand their astonishingly wide reach, grasp exactly how they impact the body, trace their often troubling history, and crucially, explore the life-saving strategies used to manage their effects.
Yeah, and what's truly fascinating here, and often quite surprising, is just how widespread these compounds really are. They exist across this whole spectrum, from essential everyday medications that, frankly, keep us healthy, to illicit substances that pose, well, huge public health challenges.
Yeah.
Understanding their core mechanisms, how they essentially hack into our body's systems, and that whole cascade of effects they can trigger is paramount. It's a really critical area of study.
So to start us off then, what are sympathomimetics really at their absolute core? How do they work their magic or sometimes, their mayhem?
Simply put, they are substances that mimic the effects of your sympathetic nervous system. Think of this as your body's built-in fight-or-flight response, right? The one that kicks in when you sense danger or need to perform under pressure. Sympathomimetics basically put that system into overdrive.
Okay, overdrive. So what does that look like?
Well, when it's activated, you'll see immediate physiological responses. Your heart rate increases what we call tachycardia. Your blood pressure elevates, leading to hypertension. Your pupils dilate. That's known as mydriasis. And you experience heightened alertness and energy. It's your body's natural alarm response, just triggered artificially, and often much, much more intensely than nature intended.
Right. And here's where it gets really interesting for a lot of us, I think, because the sources of these aren't just the illicit drugs we typically hear about on the news. They're actually found in really common medications. Things like albuterol, which helps people with asthma breathe easier, or epinephrine, used in critical emergencies like severe allergic reactions, and pseudoephedrine, that go-to decongestant you might take for a cold.
Exactly. But yes, they're also absolutely present in illicit drugs like cocaine, methamphetamine, and MDMA, or ecstasy as many know it. And like you hinted, let's not forget, even everyday products like your morning coffee and many energy drinks contain substances that act as sympathomimetics, just, usually in milder doses.
Okay, so we get that they can give you a buzz or clear your head in small doses. But beyond that immediate feeling, what happens when these systems go into absolute overdrive, when your body's alarm bell just will not stop screaming?
Yeah, that's when things get dangerous. When these systems are overstimulated, the effects can be incredibly diverse and serious, impacting pretty much every part of your body. In the cardiovascular system, for example, that general stimulation leads to the racing heart and high blood pressure we mentioned. But sometimes, actually paradoxically, blood pressure can even drop in very severe cases. It really depends on the specific substance and, the person's underlying health.
How does that work? Why the difference?
It's because these substances act like master keys, fitting into different locks on your cells. These are called alpha and beta receptors. Some keys fit some locks better than others, creating this really diverse range of effects. So, for instance, a substance like, say, phenylpropanolamine primarily activates the alpha locks. That leads to high blood pressure, but then your body tries to compensate by slowing your heart rate down or reflex bradycardia. Conversely, other agents might hit the beta locks more, which can sometimes weirdly lower blood pressure because they widen blood vessels.
Okay, complex. What about really serious heart problems?
Yeah, absolutely. Beyond those general effects, Sympathomimetics can lead to serious issues like coronary ischemia or even a full-blown heart attack. Think of your heart as this hard-working muscle, right? When its rate and blood pressure shoot up dramatically, it demands way more oxygen. If the supply can't meet that demand, you get ischemia, basically a lack of oxygen to the heart muscle itself. And potent vasoconstrictors, cocaine is a prime example, make this even worse by actually constricting the blood vessels, squeezing the heart's own blood supply. They can also make your blood more prone to clotting, which, further contributes to a heart attack.
And rhythm problems too.
Yes, dysrhythmias. These are potentially fatal heart rhythm abnormalities, a major complication. Think of your heart's electrical system like an orchestra. Beta receptor stimulation can make certain parts of that orchestra start playing extra, sort of out-of-sync beats. These are called ectopic beats. And that can just throw the entire rhythm into chaos. Some drugs, like cocaine again, also directly mess with the electrical channels in heart cells. This can potentially lead to really dangerous erratic rhythms like ventricular tachycardia or torsades de pointe.
Scary stuff. Okay, so that's the heart. What about the brain, the central nervous system?
The effects there are equally profound, yeah. We often see hyperpyrexia, which is a dangerously elevated body temperature. Along with that, you get mental status changes, and seizures are common too. This widespread overactivation of the brain comes from a massive release of norepinephrine. That's a key alertness chemical. It explains the extreme hyperretentiveness and, reduced fatigue. But it's really the release of dopamine that activates the brain's reward system.
The addiction pathway.
Exactly. That's what drives the euphoria, the intense craving, the addiction, and the high potential for abuse. In an overdose situation, you might see things like severe psychosis, these really repetitive, compulsive behaviors people often describe as tweaking, and just marked agitation.
And you mentioned kidneys earlier. That seems less obvious.
It is less obvious, but equally serious. The impact on the renal system, specifically leading to acute kidney injury, or AKI. This often happens because of something called rhabdomyolysis. That's severe muscle breakdown. Imagine your muscles overworking so much they literally start tearing themselves apart, releasing a protein called myoglobin into your bloodstream. This myoglobin is toxic to the kidneys. It just gums up the works and causes damage.
What causes the muscle breakdown in the first place?
Several things can contribute. Prolonged seizures, for one. Or being unconscious for a long time in an awkward position, compressing muscles. Even the constriction of tiny blood vessels within the muscles themselves plays a role. And hyperthermia, that extreme body temperature, definitely makes it worse. We've even seen cases of compartment syndrome. That's a dangerous buildup of pressure in muscles reported with some of these substances like synthetic cathinones, bath salts.
And it's important to remember, kidney failure can happen even without the rhabdo, likely due to direct constriction of blood vessels in the kidneys, common with cocaine, and also just from chronic high blood pressure over time.
Okay, so we've painted this picture of intense physiological overdrive. But what does this all mean when someone actually presents with these symptoms in, say, an ER? It's not as simple as it sounds to pinpoint the exact cause, is it? You're essentially looking at a person whose internal alarm system is just blaring, but for a clinician, figuring out why that alarm is ringing must be incredibly challenging. Oh, absolutely. It's like a medical detective story, honestly. So many different suspects can produce really similar symptoms. Sympathomimetic syndrome mimics a whole array of other overdoses of medical conditions. Getting the diagnosis right is critical, but often very, very difficult. Clinicians have to consider everything from, alcohol or sedative withdrawal to anticholinergic syndrome, heat stroke, neuroleptic malignant syndrome, serotonin syndrome, even specific types of antidepressant overdoses, like with MAO inhibitors.
So how do they tell them apart? What are the clues?
Well, it comes down to subtle, key differentiating factors. For example, if we look at anticholinergic syndrome, might have similar agitation, high heart rate, but the patient will be bone dry, no sweating, dry mucous membranes, maybe no bowel sounds, flushed skin. And critically, their agitation is usually a non-focal delirium. They might be confused, picking at the air. It's different from that restless, constantly moving, hyper-alert agitation you often see with sympathomimetics.
Okay, dryness is a key differentiator there. What about something like heat stroke?
Good question. Heat stroke can be tricky initially. A patient might start out sweaty and hypertensive, but as their condition worsens and they become severely dehydrated, their skin becomes dangerously dry, and crucially, their blood pressure will often drop. It's spotting these critical, sometimes subtle differences that clinicians are trained for. Or things like NMS, neuroleptic malignant syndrome, involves muscle rigidity, which is different. Serotonin syndrome often has prominent myoclonus, those jerky movements, and hyperreflexia. It's about piecing together the whole clinical picture.
That really illustrates the complexity.
Yeah.
Okay, so given these potentially life-threatening effects, what are the primary strategies for actually managing this toxicity? If someone is in this state, what's the first course of action to, pull them back from the brink?
The first, and often the most effective line of treatment, is usually benzodiazepines. Think of them as the calm-down switch. They're incredibly efficient at reducing those excessive fight-or-flight chemical effects, basically by suppressing their release in the brain. They manage the agitation, the seizures, that frantic physical activity, and they even help with cooling by reducing all that intense muscle work. The key is rapid intravenous administration, giving it through an IV, and carefully increasing the dose, titrating it, until the patient is calm and safe.
Okay, benzos first. What about the heart issues, the cardiovascular stuff?
Right. For things like chest pain or really high blood pressure, nitrates can be used. These help relax blood vessels. That can alleviate chest pain, especially if it's from coronary artery spasm, which, as we said, is common with cocaine. For more acute cardiac events, sometimes a combination of alpha and beta blockers, drugs like carvedilol or labetalol, are recommended, but usually only after trying things like nitroglycerin and calcium channel blockers first.
And this brings up that really important question, the one that might seem counterintuitive. When someone's heart is racing like crazy, you might think, why not just give them a simple beta blocker to slow it down? But why is it so critical to avoid beta blockers that don't also block alpha receptors in these situations?
Yeah, it's a vital point and potentially a dangerous trap.
Hmm.
If the sympathomimetic drug they took primarily activates those alpha receptors, causing severe vasoconstriction, and you only block the beta receptors, you leave that alpha effect completely unopposed. This can lead to an exaggerated and dangerous spike in blood pressure. You've removed the beta effect that might be helping dilate vessels without touching the alpha effect that's clamping them down. It's like trying to put out a fire by only shutting off half the water mains. You can make it worse.
Got it. Unopposed alpha stimulation. Nasty. What else for the heart?
We also sometimes use hypertonic sodium bicarbonate. That's for certain specific dangerous electrical abnormalities you might see on an EKG, like a widening of the QRS complex. It indicates a problem with the heart's electrical conduction, and the bicarb can help stabilize that. And for cardiac-type chest pain, aspirin is often given too, to help prevent further clotting.
Okay. And what about that high temperature, the hyperthermia?
Aggressive hypothermia management is absolutely critical. That dangerously high body temperature hyperpyrexia is a clear sign of severe toxicity, and it's directly linked to a higher risk of death, especially in related conditions like serotonin toxicity. So rapid aggressive cooling is essential. Cooling blankets, ice packs, sometimes even more invasive methods, and preventing continued muscle hyperactivity is key. Sedation helps, but if there's severe muscle stiffness or that myoclonus or prolonged seizures, we might even need to temporarily paralyze the patient with medication.
Paralyze them.
Yeah, with a non-depolarizing agent. It sounds drastic, but it stops the body from generating so much heat and those toxic byproducts like lactic acid from the muscle activity. It can be life-saving in extreme cases.
Wow. Are there other special considerations, maybe for specific patient groups?
Definitely. For example, patients who are already taking beta blockers for, say, a heart condition might not show that typical racing heart rate when they take a sympathomimetic. And if the drug they took also has a strong alpha component, they could get that exaggerated hypertension we just talked about because of those unopposed alpha effects even from the regular medication. And for pediatric patients, toxicity shows this really interesting bimodal pattern. Younger kids, often from accidental ingestions, usually have smaller, more self-limited toxicities. Treatment is weight-dependent. But adolescents, especially those maybe experimenting with larger doses or stacking different hallucinogenic amphetamines, they could become extremely ill. Multi-system organ failure. These cases demand very high doses of benzodiazepines, active external cooling, and just exceptionally aggressive, detailed medical attention.
Okay, what an intricate picture of how these substances hit the body and how clinicians have to intervene so carefully. Now, let's maybe narrow our focus a bit to a particularly significant subgroup, amphetamines. The history here is just fascinating, isn't it? From early medical breakthroughs to, well, ongoing public health challenges. It's almost a classic human story of discovery, utility, and then serious unintended consequences.
It truly is. Amphetamine was first synthesized way back in 1887. But it was almost forgotten, really, until it was rediscovered in the 1920s during efforts to synthesize ephedrine, another stimulant. By 1932, it was marketed as a nasal decongestant called Benzedrine. Then, 1935, amphetamine tablets became available for treating narcolepsy, and by 1938, it was even used as an appetite suppressant. But, the stimulant and euphoric effects were quickly noticed.
And the abuse started pretty early then.
Sadly, yes. Abuse was widely reported by 1940. This eventually led the FDA to ban those Benzedrine inhalers in 1959 because people were cracking them open to get the drug. World War II played a really significant role in its wider spread, too. Both amphetamine and methamphetamine were given to soldiers as stimulants, to keep them awake and focused. This definitely contributed to widespread abuse in the U.S. from the 50s through the 70s. The 60s and early 70s also saw that new wave of hallucinogenic amphetamines emerge, like MDA, PMA, PMMA.
And that led to regulation.
Right. This escalating problem led directly to the landmark Controlled Substances Act of 1970. That classified amphetamines as Schedule II drugs, high potential for abuse, but accepted medical use specifically to try and curb their diversion from legitimate sources. And for a time, abuse did decline somewhat.
But the story doesn't end there, does it? It became almost a cat-and-mouse game with regulation, where chemists were constantly trying to stay one step ahead.
Absolutely. A classic example. The 1980s saw the emergence of methylene-deoxy derivatives like MDMA ecstasy and MDEA. These were often specifically designed to try and circumvent the existing regulations. Then, the availability of ice, that high-purity, crystalline form of methamphetamine, fueled a major resurgence of meth abuse across the U.S. This continuous effort to bypass drug laws has just driven the development of even newer amphetamines, synthetic cathinones, bath salts, and more recently, things like NBOMs. They continue to pose huge public health challenges by exploiting gaps in our drug laws and, frankly, our scientific understanding.
Okay, so we have amphetamine and methamphetamine. They sound almost the same, but here's where it gets really fascinating, I think. Let's zoom in on the difference between them. How can such a seemingly small chemical difference lead to such vastly different effects and impact?
It's quite profound, actually, for such a tiny chemical change. Methamphetamine is essentially just amphetamine with one extra methyl group that's a small cluster of carbon and hydrogen atoms tacked onto its core structure.
Just one methyl group.
Yeah, but this seemingly minor alteration leads to some staggering pharmacological consequences. First, that extra methyl group significantly increases methamphetamine's activity in the central nervous system compared to regular amphetamine. It's just more potent in the brain. Second, it makes methamphetamine more lipid-soluble. Think of your brain being protected by the blood-brain barrier, right? It keeps most things out. That extra methyl group acts like a kind of VIP pass, allowing methamphetamine to penetrate that barrier faster and more efficiently than regular amphetamine. This leads to quicker and much more intense effects.
Faster onset, more intense high.
Exactly. And third, methamphetamine shows greater resistance to being broken down by monoamine oxidase, MAO. That's a natural enzyme in your body. This resistance means methamphetamine hangs around for much longer, resulting in a longer duration of action. These properties combined faster, stronger, longer, lead to an increased potential for abuse. The faster and more intense the high, generally, the more powerfully addictive it can be. And compounding the whole problem, methamphetamine production is relatively simple, often requiring minimal equipment and readily available chemicals, which contributes to its widespread illicit availability. It's truly amazing how one tiny chemical tweak can lead to such drastically different effects and, well, societal impact.
It's almost unsettling, how much power a single atom cluster can hold. To completely alter a substance's journey through the body and its potential for harm, and the complexity doesn't stop there, right? What about other amphetamine derivatives and their unique dangers?
Exactly. The specific effects really depend on where and how selectively each derivative binds to the various neurotransmitter transporters in your brain, basically, which chemical messengers it messes with the most.
Okay.
Take MDMA, ecstasy. It has a much higher affinity for serotonin transporters. This causes that potent release of serotonin, leading to feelings of empathy, euphoria. But it also carries that distinct risk of hyponatremia, dangerously low sodium levels, often because people drink excessive amounts of water while using it, trying to counter the dehydration or hyperthermia.
Okay. What about others? You mentioned PMA and PMA earlier.
Right, PMA and PMMA. These also have potent serotonergic activity, similar to MDMA in some ways. But critically, they have poor blood-brain barrier penetration. This is key because it causes a delayed onset of the desired CNS effects. Users might not feel anything for quite a while, mistakenly think the dose wasn't enough, and then...
They take more.
Exactly. They repeat doses. This drastically increases the risk of severe toxicity and death when the cumulative dose finally does kick in. It's a really dangerous feature. Then you have the synthetic cathinones, the bath salts. Compounds like methcathinone, MDPV, mephedrone, they have a specific chemical group, a ketone group, that actually reduces their ability to cross the blood-brain barrier compared to, say, methamphetamine. So they're generally less potent in the brain, but they still pack a punch. Strong sympathomimetic effects, and they come with this unique, nasty range of toxicities. Hyponatremia again, compartment syndrome, DIC, severe clotting disorder, AKI, heart muscle damage, heart attacks, seizures, sudden cardiac death. It's a broad spectrum of potential harm.
And the really scary ones you mentioned, NB-ohms.
Yeah, and here's a truly frightening class,
Yeah.
NB-ohms, or N2-methoxybenzylphenyllethylamines. What's particularly concerning about these
Oh.
is that they are highly potent 5-HT2A receptor agonists. They're effective in microgram doses.
Micrograms, that's unimaginably small.
Yeah, it is. Amount barely visible. So their key dangers are, first, this extreme potency means a very high risk of accidental overdose. Tiny variations in dose can be lethal. Second, they have limited oral bioavailability. If you swallow them, much of the drug gets broken down before it hits the brain. This can trick users into taking much higher doses, thinking the initial amount wasn't working, especially if they take it sublingually or nasally, where absorption is better. Third, they often have a delayed onset of effects, just like PM8, PMMA, again leading to mistaken redosing. Fourth, there's a huge lack of safety data because they're relatively new designer drugs. We just don't know the long-term effects. And finally, they are frequently misidentified or adulterated, often sold as substitutes for other drugs like LSD. So users take something thinking it's LSD and get these incredibly intense, unexpected, and severe reactions they are completely unprepared for.
Wow. It's a sobering reminder that the dangers aren't just in the obvious effects, but in these subtle chemical nuances, the timing, the potency, how they trick the body and the user. Beyond the immediate buzz or the delayed high, these substances can cause significant and lasting damage, both acutely and over time, right? It's not just about the moment of impact.
That's absolutely right. The toll is severe, both short and long term. Acute amphetamine toxicity primarily hammers the central nervous system and the cardiovascular system, all because of that massive release of catecholamines, those fight-or-flight chemicals. In terms of acute CNS toxicity, you'll see anxiety, intense agitation, sometimes terrifying hallucinations, seizures, those dilated pupils, profuse sweating, and that dangerous hyperthermia. What's notable, actually, is that severe psychosis, a real break from reality, seems to be a more prominent feature after amphetamine use compared to cocaine use. And the really severe brain complications can include intracerebral hemorrhage, bleeding inside the brain, and cerebral infarction, which is a stroke.
And the heart takes a beating acutely, too.
Oh yeah. For acute cardiovascular toxicity, we commonly see that dangerous high blood pressure, the racing heart, and a whole range of dysrhythmias, from just extra beats to life-threatening ventricular tachycardias and fibrillation. Other serious vascular complications can happen too. Myocardial ischemia or infarction, heart attacks, tears in the aortic dissection, acute respiratory distress syndrome, ERDS, really severe obstetric complications including fetal death, and even ischemic colitis, where part of the bowel essentially dies due to lack of blood flow. Plus, the acute toxicity can trigger metabolic acidosis, the body becoming too acidic rhabdomyolysis, acute kidney injury, and coagulopathy, that severe blood clotting disorder, often just as a direct result of the uncontrolled agitation and extreme body temperature.
And the long-term picture, the chronic effects.
The chronic toxicity is equally, if not more, concerning in some ways, leading to profound long-term health consequences. Prolonged use, often involving what users call speed runs, taking increasing amounts sometimes for days or weeks on end, can lead to an acute psychosis that frighteningly resembles paranoid schizophrenia. Compulsive repetitive behaviors become really common. Things like skin picking, severe teeth grinding bruxism, and those involuntary jerky or twisting movements called choreoathetoid movements. And there's clear evidence now of actual neuronal destruction, brain cell death caused by toxic byproducts and oxygen-free radicals generated by the drug's metabolism. We see lasting impairment. Former methamphetamine users, for instance, often show persistent problems with memory and psychomotor functions, measurable dopamine transporter dysfunction in the brain, and abnormal glucose metabolism years later.
So, real physical brain damage.
Yes. And systemic organ damage occurs chronically, too. This includes something called necrotizing vasculitis. That's where the body's own small and medium arteries become inflamed and damaged. This can affect multiple organs: brain, heart, gut, kidneys. It can lead to strokes, hemorrhage, coronary artery disease, pancreatitis, ongoing kidney injury. Cardiomyopathy, a disease of the heart muscle itself, is also reported. Even some of those older amphetamines used for diet suppression were linked to valvular heart disease and pulmonary hypertension, high blood pressure in the lung arteries, possibly due to their effects on serotonin. And of course, specific derivatives continue to have their unique chronic issues. Meth's potent cardiovascular toll, and DMA's potential neurological effects, the wide array of complications with cathinones.
It's a truly devastating picture of both the immediate crisis and the slow, grinding, long-term harm. So let's bring it back to the acute situation. If someone is in the throes of acute amphetamine toxicity, what does evidence-based management look like? How do clinicians intervene effectively?
Right. The management primarily focuses on aggressive supportive care. Stabilize the patient, manage the symptoms. The initial assessment has to be rapid. Check vital signs, blood glucose, and critically, that core body temperature. For severe hyperthermia, immediate external cooling is absolutely crucial. Ice water immersion, if possible. Cooling blankets, whatever it takes. Controlling agitation is paramount. Pharmacological control, usually with those benzodiazepines, is preferred. Temporary physical restraint might be needed just to get medications in safely, but you want to avoid prolonged restraint because that can worsen muscle breakdown. Securing IV access quickly is also essential for giving meds and fluids. If IV access is tough, sometimes intramuscular benzodiazepines like midazolam can be used initially.
Okay, benzos again as the cornerstone. What else?
Well, benzodiazepines really remain the first-line treatment for the agitation, the seizures, that muscle hyperactivity. They work well, administer intravenously, titrate rapidly, meaning adjust the dose quickly until the patient is calm and their muscle activity is reduced. Antipsychotics can be considered as adjunctive therapy, meaning added on, for really severe psychosis or delirium if the benzos aren't quite enough. But, that's a big but, with significant caution. Antipsychotics have their own risks in this setting. They can potentially lower the seizure threshold, they can mess with temperature regulation further, and some can cause dangerous heart rhythm problems themselves. So it's a careful balancing act.
And managing the rhabdo risk.
Yes, that acute kidney injury risk from rhabdomyolysis needs prompt attention. The benzodiazepines help by reducing the muscle activity causing it. And adequate hydration, giving plenty of IV fluids, along with supporting their cardiovascular system, are crucial to maintain urine output and try to prevent or minimize kidney damage.
Okay, this brings up another question that people might logically ask. It might seem intuitive to try and speed up the elimination of the drug from the body, right? Maybe by, I don't know, altering the urine pH to kind of flush it out faster.
That's a really good question, and it highlights an important point. The answer is a firm no. Urinary acidification is not recommended. While theoretically making the urine more acidic can slightly increase amphetamine elimination, it carries a significant risk of worsening acute kidney injury. Here's why. If the patient does have rhabdomyolysis, acidifying the urine can cause that myoglobin protein we talked about to precipitate, to basically solidify in the kidney tubules. That just causes more damage, and honestly, the strategy simply doesn't reduce overall toxicity enough to justify those significant risks, so we don't do it.
Got it. Don't acidify the urine. What about body packers, people who've swallowed packets of drugs?
Right. For individuals known or suspected to be body packers who have ingested packets of amphetamines, the management is similar to how we handle cocaine body packers. Any signs or symptoms of sympathomimetic toxicity, suggesting a packet is leaked or ruptured, necessitates immediate surgical intervention to remove the remaining drug packets before a massive, potentially fatal overdose occurs. And throughout this whole process, for any patient with amphetamine toxicity, continuous monitoring is key. Vital signs, mental status, urine output, it's constant vigilance. Then, once the acute crisis is over, a psychiatric evaluation and definitely referral for substance abuse treatment are absolutely essential parts of the care for long-term recovery.
Wow, what a truly deep dive this has been. We've really covered a huge amount of ground, haven't we? From the surprising everyday presence of sympathomimetics in things like coffee and cold medicine, all the way to the complex history and specific, often hidden dangers of amphetamine derivatives like those terrifying NBOMs, and then understanding the critical life-saving management strategies that clinicians have to employ. It really highlights this incredibly intricate dance between pharmacology, human behavior, and ultimately public health.
It really does. And if we connect this to the bigger picture, it's clear that the constant evolution of desired drugs poses this continuous evolving challenge. These drugs are often engineered specifically to bypass existing laws, or they have completely unpredictable effects because they're novel. It forces us to ask, How do we as a society adapt? How do we adapt our scientific understanding, our healthcare responses, our public education strategies to keep pace with this ever-changing landscape of really potent substances? It feels like a constant race between discovery and consequence.
That's a powerful thought to end on. It reminds us that being well-informed isn't just about knowing the facts today, but understanding these ongoing implications and the dynamic nature of these challenges moving forward. We really hope this deep dive has given you a clearer, maybe more nuanced understanding of these potent substances and the profound impact they can have.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.